Hi, this is Brian Kim. I want to share with you case number 105 in the Best Way to Do Cataract Surgery series. This is a patient who has intraoperative floppy iris syndrome. And I'm going to show you, again, how to leverage mechanical fracturing to minimize iris trauma. As you know, I like to use mechanical fracturing forces to disassemble the lens. I feel like this is the most efficient and safe way. You're able to crush the lens pieces and use less ultrasonic energy. You're able to hook pieces up out of the bag and minimize zonular distress. But you're also going to be able to see that I'm able to minimize any effect on the iris and the pupil in this case of intraoperative floppy iris. So use a corneal marker, which will help me to center and size a rhexis. I'm using a cotton tip to turn the eye, and then I make a paracentesis incision first on the right side and then the left side, making sure the incision is flat to the iris plane, which will create a nice corneal shelf and achieve a self-sealing incision. I'm injecting intracameral lidocaine and then now disperse the viscoelastic into the anterior chamber to fill the chamber and flatten the anterior capsule. This is the triplanar corneal incision. I make a vertical groove. Place the blade into the deep part of the groove, tunnel through the cornea. Using the cannula, I turn the eye back towards me, and then I enter. Push some more viscoelastic in, and then using forceps with the teeth sideways, I enter. I puncture the central capsule with the forceps. I pull downward. As I do this, the tear goes a little bit to the left. I use the teeth closed and redirect the tear towards me. I'm having a little trouble finding the tear. It must have turned downward, and so I'm going to have to switch to the cystotome. So I use the cystotome now to grab the tear and try to lift up the flap. And so now the flap is facing upward. I'm pushing some viscoelastic from the paracentesis incision to just make sure that the flap is actually going upward here. Using the viscoelastic to push the lens material out of the way and making sure the flap is going to be positioned in the way I can grab it. Go ahead and grab the edge of the flap, going around circumferentially, making sure the size and centration of the rhexis is going to match the corneal mark that I made before. So purp some viscoelastic out. As I do this, you can see that the iris started to come to the edge of the wound. And so this is going to be a little bit interesting. I'm going to do the hydrodissection, but before I do that, I go ahead and inject some intracameral lidocaine. Because I saw the pupil acting funny when I decompressed the anterior chamber, I push the epinephrine in, and as you can see as I do this, the iris wants to come out. And so it's okay to inject intracameral epinephrine. Once viscoelastic is in the eye, you can still do this. I'm being careful and mindful of decompressing the eye completely as I'm pushing the epinephrine in because you don't want to increase the intracameral pressure. I'm going through the side port incision now to push some more of that epinephrine. But essentially, this iris has really manifested itself as a floppy iris. So I'm injecting some more viscoelastic to push the pupil edge out of the way. And this is the Capsulorhexis hydrodissection technique. Very careful not to use too vigorous of a wave here. Go underneath the rhexis edge, point the tip down, get a nice wave. It's nice and slow. Decompress as I do this. Really decompressing really well. hydrodissecting along the left side and then turning the cannula tip down on the right, and I'm able to hook the lens and rotate the lens. So again, very mindful with hydrodissection in this situation because you don't want to cause more iris prolapse. Irrigate the surface of the eye, lift the incision with a chopper, going in with irrigation off, activating irrigation, and then removing the surface epinuclear material. Placing the chopper under the rhexis edge, contra-incisionally, the phacotip vertically sub-incisionally, crushing the lens in half with the double chop maneuver, placing the chopper around the right heminucleus, pulling it towards the phacotip, crushing it, and dividing the right heminucleus. That's cross chop. Using some vacuum, I'm going to lift that first quadrant up out of the bag, crushing it, bisecting it with the instruments, and then emulsifying the lens piece, placing the chopper around the lens, the second quadrant, pulling it centrally, dividing it against the chopper, and then using high vacuum to grab the pieces and then emulsifying the lens pieces. The lens pieces are not quite trying to come up, and I'm being very careful to make sure that I don't grab the iris in the process, and just very carefully and patiently making sure I'm able to hook the lens piece up out of the bag before I try to grab it with vacuum. I don't like to go after pieces with high vacuum if I can in this situation. So I turn the second heminucleus in front of me, placing the chopper around the lens piece, pulling it against the phacotip and bisecting the lens. Using the chopper to manipulate that third quadrant pieces, and then emulsifying the lens pieces, placing the chopper around the fourth quadrant, making sure I get all the way around it, bisecting the lens piece, using high vacuum to grab the lens pieces, and then emulsifying the lens pieces. You can see that I'm applying the high vacuum away from the iris edge because I know that this patient has floppy iris. I don't want to activate the high aspiration and vacuum near the pupillary edge. And I'm also using the chopper somewhat of a shield to protect and making sure that the iris doesn't come to the phacotip as I'm using the high vacuum. I'm grabbing the anterior edge of the epinucleus and it's prolapsing up and out. Again, being very mindful with foot pedal control about how much vacuum I'm applying and where I'm applying it. You can see that there's prolapse to the paracentesis incision, so I sweep it with the phacotip. I take the chopper out, push BSS in, take the phacotip out, and I go in with the ironing handpiece. And when I go in, I'm actually decompressing. I'm not activating the fluid and then just coming out because I want to avoid the iris from going outside of the incision. Starting sub-incisionally, I'm removing the cortical material. And you want to get right up to the cortical material so you don't accidentally grab the iris here. Switch to polish mode and polishing under the rhexis edge. I'm going to go ahead and fill the capsular bag with cohesive viscoelastic, but I make sure that the irrigation is turned off before I come out with the INA tip to minimize iris prolapse. And then I push the viscoelastic so that it pushes the subincisional iris out of the way. I go ahead and place the injector in and very carefully deliver the one-piece lens into the capsular bag. So again, while the cannula was in there to push the viscoelastic to inflate the bag. I also push viscoelastic, push the iris away in the subincisional area so that it would minimize iris prolapse. So I go in with irrigation off, activate irrigation, go underneath the lens, tilting it and rotating at 90 degrees, removing the viscoelastic from within the bag in the anterior chamber, polishing under the rhexis edge, and then I'll hydrate my incision. So again, this is a patient who showed signs of floppy iris, which began when I was doing the rhexis, and then I burped the viscoelastic out of the wound. You could see the pupil acting funny. I went ahead and injected some epinephrine, even though the eye was full of viscoelastic. Just like you can still use trypan blue when the eye is full of viscoelastic, you can inject epinephrine in the area of the iris to stiffen up the iris, even though there's viscoelastic in there. And then all the maneuvers should minimize overpressurizing the eye and then quickly coming out of the eye, because then the pupil can come out. And the most critical step really is during hydrodissection. You don't want to use a very vigorous hydrodissection wave. And you really need a technique that you know that you'd definitely be able to get that wave on the first shot. And that's why I really feel the Capsulorhexis hydrodissection technique really is a very consistent way to get that wave. You saw I got a very slow, methodical wave without the iris prolapsing out of the wound as I was doing it. And then because it has a hook on the end, I'm able to turn that lens very easily without causing much torsional stress on the zonules. And then again, mechanical fracturing techniques and keeping the phaco-tip away from the edge of the pupil also minimizes risk to the iris and causing damage to the iris. And as you can see, this case that could have been much more trouble was a fairly routine case. So I hope this was helpful to you, and I thank you for your attention.